discussant, brilliant facilitator, and august gathering. Assalamu alaikum. I'm Dr Md Matiur Rahman, welcoming you all to my presentation. And title of my presentation is What to Do and How to Do. So, brief about the history of my patient is Mr. V, 34-year-old Ukrainian, having history of hypertension and dyslipidemia, presented to us with class 2 angina. And ECG is unremarkable. An echocardiography showing hypokinetic basal mid inferior wall with preserved wall thickness and ejection fraction was 50%. Angiography was done. So, angiography was done which revealed RC is totally occluded from its proximal segment and retrograde filling from left system. And there is a minor plaque in the proximal LED, osteoproximal LED, and otherwise normal. And so our diagnosis is single vessel disease, and recommendation was PCI to RCA. And we did JCTO score, it was 1. So what to do? And our plan is to PCI to RCA. So challenges has to overcome. This is a CTO lesion and selection of guide catheter whether we will approach through antegrade or retrograde. And we access through right femoral and right radial. And to guide catheter implants, 7 French for RC and Hyperion SVP for 6 French for left. And Carabal, of course, guide wire was Sion blue, Sion black, SO3, ultimate bros, and RJ3. So we took dual injection, and there was a long segment CTO, and distal RC was visualized, and that was a good collaterals. Which approach will we take, antegrade or retrograde? First, we approached antegrade, and we took Sion wire with the support of Carabal and tried to negotiate, but could not negotiate, and goes to the dissection flap, and we switched to Sion black wire, and we tried again and again, but does not negotiate, and cross the lesion, frequently goes to the false track. And we approached, Carabal is advanced and were taken out and took a shot for tracking, and it was kept in the proximal RCA. So what to do next? As antegrade approach is not possible, so we proceed to retrograde approach. And we took a shot of Carabal, by Carabal, of mid septal branch of LED. There is a good collateral, and we took Sion blue with the support of Carabal, and Sion were negotiated but not in the main track, did not cross the collateral. So we switched Sion blue to SO3 wire, and it's crossed the collateral successfully. And microcatheter advanced to the distal RCA, and SO3 is withdrawn. And we took dual injection, and we took shot through left Carabal for distal RCA and distal cap characteristics. We tried to penetrate distal cap with Sion wire, but failed. And ultimately we took ultimate bros, and it's the ultimate driller. And finally we succeeded and crossed the lesion. Carabal was kept in the aorta, and Sion blue wire entered in the AL, and Platt's catheter with the help of cadaval after several attempts. Sewn wire was taken out and keeping the cadaval within the Emplart's catheter. And we took RJ3 wire and externalized through RCA, guide cath, pre-dilated with NC 2.515 balloon, and we took synergy to 3.548 and deployed. Post dilatation done with 4 into 15 balloon. Cadaval pulled to LED, and there is no perforation or dissection in the septal perforator. And cadaval negotiated from both sides and opposed head to head, and RJ3 were removed to avoid septal injury to the septal branch. You see, there is no dissection or perforation after removal of cadaval and wire in the collaterals. So this is the final result. So take home message, situation always challenges for interventionist. Option should keep open with the appropriate hardware, operator experience. Slow and steady key to success of CTO intervention. Step-by-step approach will enhance procedural success and avoid grave complication. It should be ensured that wire in true lumen before balloon or stent deployment. And finally, I would like to acknowledge my mentors, Dr. Kaisar Nasrullah Khan, Mominujjaman sir, and other team of United Hospital, giving me the opportunity to present this case in such nice gathering. Thank you all for patient hearing.
Thank you, Matiur, for a nice presentation. Still, we are hearing your failure of antigate, then retrogate. It's a very challenging and a brave decision to change, and also ultimately success. Thank you. Thank you.